About canine and the management of impacted canine. In this lecture, we're gonna talk starting about the development of the maxillary canine, and then we can understand the difference in the methods of localization of the canine, how we localize buccally canine, and then understand the treatment options for the buccally impacted and palatally impacted canine. So starting about a little bit of facts about the canines. Upper canines erupt usually on average at the age of 11 to 12 years of age. For the canine to be absent, congenitally absent, it's very uncommon, very unlikely. It's 0.3% of the cases. It's more often for the canine to be impacted, which is at up to 2% of the cases where you can see the canine in the oral cavity, the cause will be impaction. So impaction is the most common cause for not seeing the canine in the oral cavity, let's put it this way. So if we're going to define the impacted canine, it's a canine that is prevented from erupting into its normal functional position, either by bone, tooth, or a fibrous tissue. Now, what about the normal development? Now, the canine normally develop at about 4 to 5 months of age, which is the calcification near the base of the nose, very high up in the maxilla. Then the canine will start migration downward and forward to lie buccal to and mesial to the apex of the deciduous canine. Then it will erupt down in the distal aspect of the root of the upper lateral incisor. So basically what happened with the canine, it starts calcification near the base of the nose. Then it goes down in the palatal side of the maxilla, not on the buccal side. And then it will do the jump in which it will move from the palatal side into the buccal side, and then it will erupt. And this is very important because this jump starts to happen at the age of 8. And then by the age of 10, this canine should be palpable in the buccal sulcus. If you don't feel the canine by the age of 10, it means that this canine is impacted in the palatal side, and something we have to do to make this canine move to the buccal side. And we're going to discuss this later. So what about the prevalence? Now, the impaction, as we mentioned, for the canine, it's 2% of the cases. Out of these 2%, 61% to be palatal impaction, which is the most common form of the impaction. Then we have 34% of the cases in which the canine is in the line of the arch. Then 4.5% of the cases buccally, which is the least common form of the impaction. Now, why do we get palatally impacted canine? Why the canine got impacted? The first one is the long path of eruption. That kind of explain again the palatal canine. Why we have palatally impacted canine? It's the long path of eruption. We said that the canine erupted near the base of the nose. It moves down in the palatal side. It's a long distance. It's a long journey. There is a good chance that the canine loses its way during this eruption process. So we'll end up with impacted canine. As you can see here, the canine starts high up near the nose, then it moves all the way back into its position. So it's a very long journey. The second theory is called the guidance theory. So basically, this theory came up as after noticing that in the cases where the lateral incisor is either missing or big shaped, the canine become impacted. So what the theory came up with said, this canine, this lateral incisor, the distal side of the distal root of the lateral incisors provide guidance for the canine to erupt, and that if the lateral incisor is not erupted, it's not here, or it's big shape, the canine become missing. As you can see here, the canine kind of use the lateral incisor surface as a guidance for eruption, while if the lateral incisor is not here or it's a big shape, the canine loses its way and it does not erupt. The third explanation, or the third theory for explanation of the impacted canine, but this one explains the buccally impacted canine, which is crowding. So basically the canine develops as normally near the base of the nose. It goes down in the palatal direction. It does the jump to the buccal side as normal. Now when it tries to erupt, there's no space for the canine to erupt, so then the canine become buccally impacted. So most of the cases that resulted from crowding, in the crowded dentition, it will result in buccally rather than palatally impacted canine. Now the fourth theory is called the genetic theory, which explains why do we have impacted canine. And this one as well cover the palatal one, the palatally impacted canine. Now when you say genetics, you need some evidence that there is a genetic inheritance of the canine. The first one, it runs in different populations. So different populations have different incidence for impacting canine. It affects the females more than males, which means that there is some genetics background. And also, it runs through the families, so you can see it through the siblings. And it can occur bilaterally with a greater than expected frequency. And sometimes it happens with other anomalies, like, for example, syndromes like cleidocranial dysplasia. It can happen with missing laterals or big-shaped laterals. So all of that give you an evidence that impacted canine could be genetics. So to summarize up, genetics, long bathyral eruption, guidance theory explains the palatally impacted canine, while crowding explains the buccally impacted canine. So when you do the examination, it's essential and mandatory to palpate the canine at the age of 10. Canine should be palpable in the labial sulcus by the age of 10. If the canine is not palpable by the age of 10, then we should start thinking about interceptive treatment. So this is the area where the canine usually palpable in the labial sulcus. Now, when you get the patient into the clinic, we need to do the examination for this patient. Now, the examination starts with examining the patient, the canine position, by doing palpation. You look at the lateral incisors and see if there is any mobility for the lateral incisors, for the C if there is any mobility, any color changes of the teeth nearby. If you find everything normal or if they are suspicious, then we go to the radiographic examination. So as we said, first palpate, then check the mobility of the adjacent teeth, check the color of the adjacent teeth, angulation of the lateral incisor. So for example, sometimes the canine could just push the tooth. Like here, the canine is resting against the root of the lateral incisor from the mesial side, like there is a transposition. So as you can see, the lateral incisor is flared in this photograph. So this is how we should do the examination before taking the x-ray. So you need to check, to palpate with your hand, with your finger, see where is the canine. You need to check the mobility and the color changes of the adjacent teeth. You need to check the angulation of the canine if any changes happened. Then we move to the radiographic examination. When you take a radiograph, you can tell the relationship between the canine in the line of the arch with the lateral incisors, but you can't tell where is the canine in the buccal and palatal direction. You can't tell if there is a resorption from the lingual or the palatal side of the canine or the buccal side, because simply this is a 2D image for a 3D structure. The other option to take is the periapical, where you can look more into the relationship between the canine and the lateral. Some people use the canine, the lateral cleft, to detect the palatal position of the canine or the buccal, because as you can see here, these are the incisors and this is the canine here. It's in the more into the palatal position. But if you have one x-ray, you took an OPG and you need to locate the lateral inside the canine, you need to take two x-rays. We call these techniques parallax techniques. There is two options for parallax. We can have vertical parallax, in which the tube shift will happen in the vertical dimension, or you can do a horizontal parallax, in which the tube shift will be done in the horizontal dimension. Let's here explain this parallax or slope technique. So you take an x-ray, as you can see here, we have a green object and we have red object. And this is how the red object will be, and this is how the green object will look like. Then we do a shift in the tube in the mesial direction, or toward the right hand side, as you can see. And you take the new option, a new x-ray, and you can see that now, if we assume that this is the distal side and this is the mesial side, alright, so your left hand side is the distal side. As you can see now, the red dot is distal to the green dot in this x-ray. When the cone moved in this direction, the red dot moved in the same direction as the cone. Same lingual, opposite buccal, it means that the canine is in palatal position. Again, I will do that again. Once we shift the tube from here to here, which is from distal to the mesial side, the red dot from this x-ray to this x-ray moved in the same direction as the cone, which means that the red dot is same lingual, opposite buccal, so the red dot is palatal, as we can see here in the diagram. As I mentioned, we have two methods of parallax. We have horizontal parallax, in which the shift of the tube will be done in the horizontal direction. And this can be taken most commonly by taking two periapicals. You take the first one, you do the shift of the tube, and you take the second one, or you can take anterior occlusal and periapical. Both of them has a kind of shift in the horizontal dimension. The other option is to do shift in the vertical dimension. So you take an X-ray and then you repeat it with the cone moving upward. Now, when you take an OBG, remember that the angle between the cone and the X-ray film is about 0 to 8, while the angle between the X-ray film and the X-ray beam is about 65 degrees, which means, as you can see here. So from this position to this position, the cone moved up. So vertical parallax can be done by OBG and anterior occlusal, or OBG and periapical. So here, if you want to do a practice, just a little bit of practice for this one. Let's look at this side here. From this side, look at the cusp tip of the canine in relationship to the root of the central incisor. You can see that the cusp tip is within the middle third of the root. If you take a periapically do shift, you can notice that the canine did not change from here to here, which means that this canine is in the line of the arch. It did not move. It's within the line of the arch. So that's how we use the vertical parallax to locate the canines. If you look at this one here, in the OBG, the canine is located almost in the apical third of the central incisor. When you take a periapical, when the cone moved up, the canine moved in the opposite direction, which basically in the middle of the crown. As you can see, here's the middle of the root. So from here to here, the canine moved downward, which is the opposite to the direction of the cone, which means the canine on this side is buccally impacted. Now, sometimes you need to take a 3D image because you can't tell the relationship between the canine and the lateral incisors carefully. For example, look here, the canine could be buccal, could be palatal. We can know that by the parallax. But when it's buccal or palatal, we don't know if there is a contact between the canine and the lateral incisors, and if this canine causing any resorption to the lateral incisors. As you can see here, the canine can cause resorption to the central and lateral, and one way to do this, to diagnose it, is by using a cone beam CT scan. Now, for the management of the canine, now management of buccal canine is slightly different from management of the palatal canine. Remember that the buccal canine, the etiology mainly is crowding. The canine is doing the job, it's making the jump, and then they don't come up because of the crowding in most of the cases. So if you have a buccally impacted canine, first you need to create space, and then you need to uncover, you need to expose this canine and attach something to bring it down. We call this a surgical exposure. For the impacted canine in the buccal direction, we have two options for the surgical exposure. The first option is called a buccally positioning flap. Now, remember something, that when the canine erupts, it has to erupt in the attached mucosa. Now, as you can see here in this photograph, we have alveolar mucosa, which is non-keratinized. We have attached mucosa, which is this one, which is keratinized. If the canine is about to erupt, it should erupt in the keratinized mucosa, not in the alveolar mucosa. So, if you look at this canine, what we need to do with the apical positioning flap, you open a flap, you raise it, and you lift it up. You move it upward, so you preserve the attached mucosa. And then you bond a bracket to the tooth and you bring it down. The advantage for this technique that you can see where is the canine going to go. However, we can't do it in all the cases, because when you do a buccally positioning flap, you might jeopardize the attachment on the neighboring teeth because you're moving the flap apically. For that reason, if we can't do a buccally positioning flap, simply you open a flap, you bond the bracket with a chain on this canine, and then you close the flap and you start traction. We call this closed exposure for the canine. So these are the two options for the management of the buccally impacted canine. So we have canine that's buccally impacted, you create space, then you do open exposure, or a buccally which is a buccally positioning flap, or you do closed exposure. Now, what about the palatal canine? Management starts with the interceptive. We mentioned that you need to do palpation for the canine in the buccal sulcus. Palpation should start by the age of 8. Then by the age of 10 to 11, if the canine is not there, we take an x-ray and we confirm that the canine is palatally impacted. Now before taking an x-ray, you do the clinical examination as we mentioned. You do the palpation, you do check the mobility of the neighboring teeth, you check the color changes, the angulation of the teeth, and then if you don't see the canine, you don't feel the canine, you do the investigation, you take an x-ray. If the canine is palatally impacted, there's an interceptive treatment that we can do at the age between 11 to 13, not more than 13, which basically extraction of the C and fitting the patient with a space maintainer like a TPA. As you can see in this radiograph, the canine is in the palatal position, extraction of the C is done, canine is coming down, and canine finally erupted into the oral cavity. So this is kind of, we call it interceptive orthodontics for the management of the impacted canine. The second option, as we mentioned before for the buccal one, we expose this canine, we bring this canine down to the line of the arch. However, in order to do this, our patient has to be very well motivated because that's a long treatment time. You're going to spend almost 2 years treating this patient, so basically he has to be motivated and well cared for his dentition. We need to create space and also the most important one, favorable canine position. We want to start alignment of the canine that is not in a favorable position. How we study the favorable position of the canine? We look at 4 factors. The first one is the position of the apex. As far as the apex goes distally, as far as it's more difficult for this canine to be aligned. So we divide them into grades, grade 1, 2, or 3. Grade 1, where the apex is like above the region of the canine, which means it's very close to the area where it should be in the end. However, grade 3, it goes where the cusp tip of the root apex, of the canine is above the second premolar region, which means that we need to bring it all the way here, so that make it more difficult canine. We also look at the alpha angle, which is basically the angle made by the long axis of the canine and the mid-sagittal plane. The more the angle, the more horizontal the canine, the more difficult to align this canine. Then we look at the vertical height of the canine. So you divide it into 4 grades. At the level of the crowns of the incisors and canine, or we call it below the level of the cemento-enamel junction, it means that it's an easy canine. If it is above the length of the roots here, above the apices of the root, then that's kind of very difficult canine to be aligned. Then also you measure the horizontal position, measured by the horizontal overlap between the canine and the lateral incisors. If the canine cusp tipped, usually we look at the cusp tip of the canine region, that's a grade 1, easy one to do. If it's at the central incisor region, that's a difficult canine to do. If it's just in the distal aspect of the lateral, that's called the grade 2, which is kind of easy case. Grade 3 is a moderate kind of case as well. So now we agreed on the options for if the canine is easy or difficult to align. Now again the exposure option. As we mentioned for the buccally impacted canine, we have 2 options. We have open exposure and we have closed exposure. For the open exposure, you simply open the flap, remove the bone, remove a chunk of the soft tissue, and then close the flap, and you still can see the crown of the canine. You still can see the crown of the canine. So basically you do this. You open a flap, you remove the bone, you remove a soft tissue, we can see it. Now, the advantage for the canine is that the canine in the palatal side, it's all attached mucosa. So we can easily do an open exposure in the maxilla, in the palatal side, not compared to the buccal canine. The other option is to go for a closed exposure. For the closed exposure, simply we raise the flap, we open a flap, we remove the bone, and then we bond what we call a gold chain, like this one, into the canine, and then we start traction for the canine. So we can see the canine during the traction. So the main advantage for this one, if we compare the open to the closed one, in theory, it's more comfortable for the patient because the patient will not go with a big wound opened. The other option, which is only theoretical, that we'll have a better gingival margin around the canine because it's erupt as a natural eruption while in the open exposure, it's not kind of natural. However, all the evidence showed that both of them at the end, they will have the same results. Now, the disadvantage for the open exposure, that the gingiva might cover the tooth again and you need to expose the tooth again. While the disadvantage of the gold chain or the closed exposure, that this gold chain can be debonded and then you have to do the surgery again. So there's no one better than the other. It's both of the techniques are good. It just depends what the surgeon or the orthodontist is comfortable with working. Let's check this case and see how to manage. So if you look at the upper arch, you can see that all the teeth has erupted except the upper left canine. And as we mentioned before, if we have a tooth that is not erupted yet, what we need to do is to check the sequence of eruption. Which tooth erupt after the canine is the sevens. So usually the canine erupt in the sevens. As you can see here, both sevens are erupted. If you look to the contralateral side, the canine has already erupted, which may have obviously more than 6 to 9 months. So there is something wrong with this canine. Now, we usually do palpation. If the canine is not palpable by the age of 10, we suspect something. Between 11 to 13, we can do an interceptive treatment. But this patient is already 14, so she's past the time of interceptive. So what we should do? First, we need to do a clinical examination. We do palpation for the buccal sulcus. For the palatal side, we need to check where is the canine. And then we check the mobility of the lateral, we check the displacement of the lateral, we check the color changes of the neighboring teeth. All look normal, it's fine. We move to the next step, we need to take an x-ray. We take an OPG and to check where is the position of the canine. If we look at the canine, we can tell that the canine is there, but we can't tell whether the canine is buccal or palatal. So we need to take another x-ray, which is here, anterior occlusal. With anterior occlusal, we did a vertical parallax. So at this x-ray, the cusp tip of the canine is at the level of the middle third of the root of the lateral of the central incisor. When the cone moved up, the cusp tip moved in the upward direction as well. Now it's in the apical third of the root of the central incisor. So the canine from here to here moved upward. It's in the same direction of the cone from here to here, which moved upward as well, which means same lingual, opposite buccal, which means that the canine is in the palatal position. So here's the patient, done the exposure, extrusion, then bringing the canine into the line of the arch. Now, the other option, so we mentioned now so far 2 options for the management of the canine. One is interceptive, then exposure. The second one is extraction. So if you do charting for this patient, you have 6, 5, 4, 2, 1. So we have a good contact between the 2 and the 4. The 4 look like a canine, so why to align the canine? So one option is just to extract the canine or leave it for observation. Don't do anything for this canine and keep taking an x-rays every 1 year to check if there is any cystic formation around the canine. Usually we are worried about a dentigerous cyst forming around the canine or the canine migrating within the bone causing any resorption. So we have to take an x-ray regularly to make sure that the canine is not causing any damage. So we usually like the canine. The canine is a big tooth, it's the corner of the mouth, the canine eminence are good, canine guidance, we like the canine, so we prefer always to bring the canine down. However, if we have like a good 2 to 4 contact, if the oral hygiene of the patient is questionable and you don't want to spend 2 years of the treatment, then extraction of this canine could be the option. The third one is the transposition. Meaning of transposition meant exchanging the position of the teeth. So if you can see here that this is the canine, this is the lateral, and this is the C. Canine has an exchange position with the lateral incisor, and this is a complete true transposition. Whenever we have a complete transposition, we can't really correct it because at some point the canine and the lateral will cross over against each other, which might cause gum recession of the around the canine or even bone resorption. For that reason, we can't correct it. What we do is we accept the transposition, we bring the canine into the position of the lateral, and then we do reshaping of the canine to look like a lateral. As you can see here, it's slightly dark in color. Here we did a little bit of reshaping for the canine. Thank you very much.